Welcome to our panel discussion on innovations in mental health care access. How do people access mental health care? Many New Yorkers are feeling anxious and sad right now, and as the COVID-19 crisis continues, the need for mental health support will likely only intensify. Today we're talking to 2 insurance providers and 2 city officials. All of them will be part of the solution we need to move forward. We'll talk about what New Yorkers need to access mental health care. We'll discuss how insurance providers can promote mental health and how they are changing their practices in response to the coronavirus outbreak. We'll also discuss the types of innovation we need to ensure that we build a mental health system that is responsive to the needs of our communities. My name is Susan Herman, and I'm the director of the Mayor's Office of ThriveNYC. At its heart, Thrive is about making sure that every New Yorker in every neighborhood in the city who needs or wants mental health support can get it. We focus on mental health for New Yorkers because there are gaps in our mental health care system, and that means that hundreds of thousands of New Yorkers with mental health needs are not connected to care. Thrive fills gaps by bringing more mental health support to more New Yorkers in places that haven't had it before and in new and innovative ways. We currently partner with 12 city agencies and over 200 community-based organizations to provide mental health programs that reach hundreds of thousands of New Yorkers every year. We reach people with the highest need, those with serious mental illness, those harmed by trauma, and those living in historically underserved neighborhoods. And much of our work focuses on making sure every New Yorker has access to mental health support where and when they need it. Many New Yorkers, and particularly New Yorkers of color, face critical barriers to mental health care for various reasons, including a serious shortage of mental health care providers, a lack of providers trained to provide culturally competent care, stigma, and a lack of medical insurance or a lack of comprehensive coverage, to name a few. In the context of COVID-19, these barriers have only been exacerbated by a healthcare system that is overwhelmed and is straining to meet the basic healthcare needs of New Yorkers, with some of the hardest hit hospitals located in communities of color. We know that extreme levels of loss and economic hardship will only make behavioral health needs more profound in the coming months. Experts predict increasing rates of depression, anxiety, grief, and trauma, with grave repercussions on mental health care in the short term and beyond. We also know that public health officials and insurance providers play a critical role in promoting mental health through both preventive care and treatment, in the more typical times of individual need and in times of citywide crisis. That's why I'm pleased to present today's conversation about innovations in mental health care access during COVID-19. It's really my great pleasure to welcome our panelists. Please allow me to take a moment to introduce them. Marjorie Cadogan is the Executive Deputy Commissioner at the Office of Citywide Health Insurance Access at New York City's Human Resources Administration, or HRA. Marjorie brings years of experience working across the nonprofit and public sectors in New York City. Currently, her work focuses on connecting New York City residents and small business owners to coverage and care by conducting outreach, education, and training on public and private health insurance. Mario Schlosser is the CEO and co-founder of Oscar, a health insurance startup that is using technology, design, and data to help humanize and simplify healthcare. Mario brings his entrepreneurial perspective working in consulting, finance, and a startup founder to our discussion today. Karen Ignagni serves as president and CEO of EmblemHealth, one of the nation's largest nonprofit health insurance, serving more than 3.1 million people in New York tri-state area. In partnership with the City of New York, Emblem has expanded access for many and introduced a focus on preventive and primary care. Throughout her career, Karen has been widely recognized and celebrated for her leadership in healthcare reform, including her work on the Affordable Care Act. Dr. Michael McRae is the Assistant Commissioner at the Department of Health and Mental Hygiene in the Bureau of Health Promotion for Justice-Impacted Populations. He has dedicated his career to addressing health inequities, working to ensure the most marginalized populations can access care by implementing trauma and resilience-informed, evidence-based approaches in behavioral health. As a trained psychologist, he offers an important clinical perspective on the mental health needs of New Yorkers. That's our panel. It's an honor to be with you today, so let's get started. I'd like to begin by asking you to paint a picture of New Yorkers' need for behavioral health services. Michael, what kind of behavioral health needs were you seeing in our communities earlier this year, and how has that changed since COVID-19? You're on mute.
Thank you for having me. Thank you for the question. As you mentioned, I've done many years of community outreach and engagement to really try to work with various communities that are marginalized in order to help them get access to care. And I've tried to use very innovative processes or programs and such to get them access to that care. I will say that prior to COVID-19, there was lots of, there's always been discussion around stress. There's always been discussion around depression and anxiety. But I also think there was a reluctance to access care in many ways due to stigma, due to ongoing mistrust around government and medications, and kind of, just based on historical events. I will say that, the COVID-19 pandemic has really brought about, in many ways, I think is actually more of an openness even to access care. I can say that even anecdotally, just kind of speaking from my own experiences, that folks are actually much more, I'm seeing that people are much more actually open to accessing care, maybe due to the telehealth kind of piece, right? Oftentimes, the travel there, the travel back, being in the same room with a person, was sometimes seen as kind of as a barrier. And I think I've seen that communities are actually much more open to actually receiving care.
Very important point that the way of offering care could have just in itself been a barrier.
Yeah, the way of offering care is a barrier. I think just kind of clinically, I mean, if you're not in the same room with somebody, there's a distance. I think it's actually a good way to actually invite people into the therapeutic process.
Yeah.
And speaking with communities, I speak with community-based organizations, faith-based organizations, community members from all across the city. And what is consistent is that they are experiencing stress, they're experiencing a lot of anxiety, depression, but they're also having more conversations about it. And so I think that kind of one of the things that I'll talk about in a lot today is really just destigmatizing by having conversations and normalizing the process of stress, particularly in this in the pandemic. Susan, you mentioned earlier, this is a trauma. This is trauma. This is a global trauma that we're all experiencing. Some in different ways than others, but we're all kind of in. I heard someone say the other day, we're all in the same storm. We're just in different boats.
Yes.
And so I think, but there's also connectivity and a lot of around shared experience. So even though it's a trauma, I think people are actually, they're connecting around the experiences that they're having within that trauma. So I think actually it's an opportune time for for people to really be accessing mental health care. And I think that there is an appetite for it.
It's good to know that actually as the need increases, the demand for it may actually increase as well, that people may be more open for it, which is really good.
Absolutely.
I take that as a hopeful sign.
Yeah, and we do know that people are calling NYC well,
Yeah,
much more now, which is a great thing. That means people are open and they're reaching out. They want these services, and
yeah,
NYC well, they can have the conversations. They can have these kind of anonymous conversations, but they can also get access to services or referrals to services.
yeah, yeah.
Um, referrals that feel like they're people that they want, based on demographies or kind of they're able to kind of spice it up. And so I think that giving people the kind of the ability to access who they want, and I think virtually, I think actually opens the door. That can be great. It's not without its challenges, but I think it's a great step in the right direction.
We'll get to the challenges, but it's a good beginning note that there's openness. Marjorie, you focus on helping individuals, and I'd like you to talk a little bit about what tools individual New Yorkers have to access behavioral health services, insured, not insured, what barriers an individual faces from your perspective.
Thank you, Susan, and thank you for this panel. It's so timely.
Yes.
I think New Yorkers are quite fortunate in many ways with regard to the foundation of coverage that exists for New York City residents, New York State residents. We have the benefit of being in a state that implements the ACA and in many ways goes beyond in terms of protecting the benefits and protections that exist there. So New Yorkers have a marketplace that allows them to get a fairly full range of coverage, expanded Medicaid coverage, CHIP coverage for children, the essential plan, which is some of the most affordable coverage for New Yorkers, and private health insurance. And the tools that have been created by the state, particularly during this crisis, to make that coverage more available, easier to get for individuals, have been manifold. So we have a special enrollment period that is COVID specific, that goes through the middle of June, so that folks who are uninsured should be approaching 311 to say, I need health insurance, how can I get it? And they'll get connected to a navigator who can walk them through the process.
So let me ask you, for people watching this now, if someone calls 911 and they're connected to a navigator, is the navigator telling them about many different kinds of insurance plans, private, nonprofit?
What the navigator is going to walk them through is the process in the marketplace that will look at their household size, their income, their health-seeking habits, and connect them to coverage that's best for them.
Okay.
That could be Medicaid. That could be the essential plan where they'll pay no more than $20. Or it could be what's known as qualified health plans, that's private coverage with the benefit of financial assistance that could be tax credits or more than that.
So might they get connected to either Oscar or Emblem?
They might be connected to Oscar or Emblem based on their choice and what works for them.
I just want to be clear that you talk about a wide range of options and you work really closely with individuals to help them work their way through it, literally to navigate it, and help them decide which is the right plan.
Right. So
service.
we partner with a lot of organizations, both the operating health plans in the city, as well as the feet on the street, the navigators, the certified application counselors, the marketplace enrollers that work with the plans to get the word out about what's available, to be available, and now telephonically available.
Yes.
And to do so now in a way that's less stressful. We're not so worried about the documents that you need.
Right.
We're not so worried, particularly for special populations, those who are 65 and over or have disabilities. There used to be certain conditions that you had to meet before you could get coverage. We're not so concerned about that. We're not so concerned that you need to renew on time. The New York State of Health has expanded the window for renewal. In fact, for folks over 65, they're getting an extra 12 months. So there's been lots of recognition that we don't want to create new stresses in the insurance enrollment process.
Great.
So that, I think, should give folks that can get coverage, and even if you think you can't, seek it out, because there are so many opportunities and protections in this state and in this city that can allow you relief.
Is your ultimate recommendation, the ultimate takeaway, that and call 311 and you'll get connected?
That is the takeaway. Call 311. Say, I'm looking for health insurance. If I'm a senior, I'm looking.
And it'll get to you.
And someone will
Your
channel
team.
you to a way to figure that out.
Yeah, great. Okay. Thank you so much.
Really.
That's very useful advice for New Yorkers. Mario and Karen, and I'm gonna turn to Mario first and then Karen. You know, the Washington Post has just reported that there are surveys indicating that 1/3 of Americans are now showing signs of clinical depression or anxiety, which is about double what it was in 2014. Other surveys indicate that half of Americans have said that this crisis has had an impact on their mental health. But when you're talking about 1/3 showing clinical depression or anxiety, we have a mental health crisis on our hands. Could you describe what your standard behavioral health coverage is? What do you cover? And has demand or utilization changed since COVID? How have your policies changed? Just paint a picture for us about what Oscar's doing.
Yeah, absolutely. First of all, it's great to be on the video chat. Thanks for doing this. Extremely important, timely topic, and it has been one we tried to tackle head on as well at Oscar. I would really just want to make sure I also reinforce what Marjorie said. Reach out to 311, to brokers, to the marketplace to try to find coverage. A lot fewer people are covered than should be the case, and a lot more people can get subsidies from the government, can get coverage than I think generally people would think. And the process has gotten a lot more easy with the marketplace now in place. So for us, in terms of mental health benefits, we offer a number of things. We, for example, have a crisis hotline, free 24/7 access to crisis intervention via phone by a trained professional. We currently actually in New York make tele-mental health visits completely free. So any mental health provider in our network, you can currently, and who you can have a telemedicine visit with, that currently has no copay. And that's something where the state has fortunately put in place actually as an additional kind of guideline regulation for the insurance companies. And that's, I think, been a great thing to put in place as a benefits design there. We have a relatively broad network of providers in New York City that you have access to really across the spectrum of mental health conditions you might face. A number of other things like mental health landing page on our website where we can walk you through these conditions, how to reach out and get care, and so on. Importantly, also, what we specifically have done is we, on the customer service side of Oscar, give you a concierge team. Is about a 5-person team. Of these 5 people, one is a nurse, and those 5 folks will actually cover you and folks who live around you. So they're sort of like geographically focused. And they will be the same 5 people that you will always talk to whenever you call or chat with Oscar. And so we use that team to really build a level of trust with members before they might even have any kind of issues that they start feeling, and that then generally we think provides for a better way to then provide access or lower the barriers of members to say, I want help and I want to seek behavioral health, mental health coaching, mental health help now. What we've seen in terms of demand changing is, has been quite dramatic, I would say. So the demand for tele-mental health is up about 4 times as compared to last year at this time. We look at what search terms are people looking for in the Oscar mobile app or the website. In New York City, actually, even before COVID, the number 2, number 3 search reason has always been anxiety and depression. So mental health have always been in our New York population pretty highly searched for terms that comes directly after the annual wellness visits. So the kind of second and third most frequently searched term is anxiety and depression there. What's come also up now to the next level there in terms of diagnosis is trauma and stressor-related disorders. That hasn't been that high and wasn't that high in the past, and that's clearly now in response to the COVID crisis.
Can I ask you about grief? Are you also hearing about grief and complicated grief?
That we have not seen as much, fortunately, hopefully, but it may be in some of the other kind of reasons there as well.
Sure. It can be wrapped into depression. Yeah.
Exactly. And so that is all certainly happening. I think what we've also tried to do, I want to kind of also reinforce what Michael said there as well, as I think when we talk to members, or when the concierge rooms talk to members, the biggest two reasons that people don't seek out mental health is, on the one hand, the inertia to overcome to, kind of almost admits that you want that help. I mean, that's certainly one thing. Mm-hmm. And then the second piece is that people just don't know what kind of coverage they can get. And so in order to overcome those two issues, we've been really very proactively communicating. We send secure messages to members all the time, emails, recorded blog posts and things like that. In fact, actually one of the highest read posts on hioscar.com right now is an interview I did with the CEO of a company called EmblemHealth, which is a New York-based mental health type of co-working space provider. They gather together mental health professionals, make it easier for them to have an office and have a billing system and things like that.
Yes.
And so I had an interview with Harry Ritter, Dr. Harry Ritter, who runs that company. And so I think that to me illustrated that it is important that as leaders, we talk about this as well, mm-hmm. because I think that by in of itself lowers perhaps a bit of the stigma of seeking access there. And I think the last thing I would say there is inside the company, we try to bring these issues up very proactively as well. I certainly feel it myself after being cooped up at home when the Upper West Side, I got a 6-year-old and a 7-year-old. There is an undercurrent creeping in with pretty much everybody I see on video chats every day. That you are getting more down. It's hard to get out of bed in the morning. It's hard to kind of do the things you got to do to get through the day. That is even for me the case. And so that is if we put this out in the open, I think that usually helps people as well in the company at least say, okay, even Mario feels it, that means I should seek out help, even if it's just from the manager or a friend in the company.
Yeah, I'm smiling because I think that even me or even Mario or even, it's sort of this, I think that we're all experiencing this loss of our former life, whatever it was. And that has to have an impact on everybody. Yep. But I think there is this sense of, oh, really? You too? And yeah, even Mario is feeling.
I don't mean to say it that way, but people.
No, I know what you mean. I know what you mean.
Mario can call somebody or whatever, and it's.
Yes. Okay. I know what you mean.
It's the same boat there. Yeah.
Yes, we're all in the same storm. Yeah. Karen, what are you seeing that's different than what you were seeing before?
It's a great question, and I want to thank you, Susan, for the invitation to participate and be with this terrific panel. I've been thinking a lot about your question because, invariably you think about the old, now the new normal, and what's the future normal going to be looking like. And I want to come right behind where Mario left off. I think one of the most important things we can all do in our respective organizations is speak very frankly about the stress of working at home. There's no break between personal and professional, the relentless 7 days, which feels like 20 days every week, and just be able to give people permission to talk about that. I think as leaders, that's one of the first things fundamentally we can do. We have comprehensive benefits. Mario did a great job of outlining them. Ours are very similar. I think most health plans have the same kinds of comprehensive packages. We found that things like acupuncture added to benefits can play a very important role in stress. Now, during these times, no one's going out for acupuncture, so they're facing more stress, but that's something that we've actually built into the mental health side of our benefits packages as a support therapy. We also do quite a lot of therapy support. We have focused on telehealth prior to this, but we are learning that people feel more comfortable talking to a clinician on the other side of the screen than they do on the other side of the desk. And so we're going to be building on this with digital health, telehealth, and a number of other tools. The other thing that has hit us over the head is that, and Michael was getting into this, and I think quite appropriately so, all of us have looked at the symptoms of COVID. You know, we have them memorized, we see them, but we don't so much see the symptoms of stress and mental health. And I think as you know, Thrive, for example, has played such an important role getting that information out into people's hands. We realize on our website that we could open the windows of our health plan, not only do the kinds of things that Marjorie was talking about, help people get coverage who've lost their employer-based coverage, help them get unemployment insurance, help them get small business loans. So we're really beginning to think more broadly about that, but get our customer service folks to help elicit from individuals what are the other issues that they are struggling with. And for us, there are 3 new issues. One is loneliness. I live on the Upper West Side too, and I see every day people going out in the streets, walking alone. And I wonder now to myself, because I'm hearing so much from our customer service teams about loneliness, are they going home alone? Are they interacting with everyone? So now I've taken it upon myself when I go out and walk to just say hello to people. Yeah. Just, you know, I feel like that's something we all can do. So number 1, loneliness. Number 2, fear. Our own teams. We've put out a schedule of how we're going to be getting people back to work and when and the earliest we would bring people back. And we are very cognizant if people are afraid to get on subways, afraid to get on buses, afraid to get on the Long Island Railroad or New Jersey Transport. And so we've been very, very thoughtful about how do we give people peace of mind who work for us, who are helping people who are calling us, who are our customers dealing with these issues. But if our own employees don't feel that they have peace of mind, they can't appropriately help others. So we're pushing that open date back so people don't have to worry about kids and juggling a number of things. So the fear is the second. And the third, you raise grief. I would put it in the bucket of bereavement. What has changed me personally is calling our team members whose spouses, children have passed away from COVID, and dealing with the inability to bury them, the inability to know where they are, to contact a funeral home, to be with them when they pass. I can hardly talk about this without tearing up, frankly. And that's something as health plans, we have an opportunity to provide support, to provide space for people to say, I am sad, I don't know what to do, I need help. And I think all of us in the health plan community are beginning to think much bigger about what should people expect of us and what can we give them? And then how do we do that through various tools?
This is fascinating to me. I'm hearing both of you say how, all of you actually, how much telemental health has helped people get past initial barriers. I wonder a little bit whether we're ever going to go back or whether that will become the way people want to interact with therapists and counselors.
I don't think we're going back.
Okay. I'm also hearing we need to be communicating to New Yorkers all the full menu of things that we offer so that they know that we're there. Michael, you work in communities every day and have for years and years. Are there ways that you would recommend that insurance providers communicate so that people know better what's possible?
Yeah, I mean, this is that's a great question. I always think about kind of reaching into the community. How do you actually connect with people that you want to connect with, and kind of starting from there? And so, kind of the way I've done that, just kind of as in the Department of Health, has kind of gone in there, asked people, talk to them, kind of figure out what their needs were. And so I think I think of like a kind of a similar process that would be helpful for insurance companies is to go into the places that are most affected and figure out kind of how are ways that we can kind of reach them non-traditionally, in non-traditional ways, you know, not everyone's checking the website, or doing these kind of, not everyone has technology to be able to figure out how to navigate a website. I've been on them and they're difficult to navigate at times. So I think it's about kind of making it more streamlined, accessible, but also figuring out kind of what are the things that people are asking for in those neighborhoods, and then speaking to those things in a very non-stigmatizing way.
Mm-hmm.
I really liked kind of the conversation around using non-traditional ways of thinking about therapy or mental health in terms of acupuncture, kind of putting it in that bucket, because I think that we can't really, everyone's not ready for that kind of that therapy session, whether it's virtual or not, right? I think one of the things too, and I don't know kind of what place the insurance kind of world has in this, but what I'm finding, people are anxious and depressed and sad and traumatized about losing their jobs, about not having food insecurity. So we have really taken a kind of an approach at thinking about how we can get people's basic needs met, and making sure that they can get their basic needs met. Because if you don't have food in the refrigerator, then therapy, whether it's virtual or not, really go ahead. I mean, I spoke. Go ahead.
No, go ahead, Michael.
And I may be veering off, but I spoke to someone maybe about a month ago, and this is a very poignant kind of conversation. She was 10 people in her home, in a 3-bedroom home, from ages 4 to 76. The 2 older people were 76 and 73. Both were immunocompromised, and 2 of the adults had to work outside the home every day. And so it's like, talking about stress and anxiety and kind of coping and, counting to 10 is great, but you can only kind of come to that space if your basic needs are met. So I don't know whether that would be the ability for you guys to promote kind of making sure that their kind of people's basic needs are met, and that being a part of mental health. Because I don't think you can look at mental health as just this kind of siloed place where you go to therapy and that's it, right? It's much more comprehensive. It's not about just mental health, it's physical health. It's getting your social needs met. And so I can really appreciate the conversation around, particularly around Karen, talking about, loneliness and grieving and kind of how that's different and how, but again, we're all kind of experiencing this together, right? And if you're from New York, you know a lot of people who have been going through this, right? People living 7 to 10, 20 people, in churches around the city. And some families, several people are dying in one household even, so, or have died. So, again, the pullback, I think, is about understanding what are the needs of those communities and then being able to reach them through ways of folks who work with those communities.
Exactly.
Yeah, I think that's really a very important point, and you're challenging us to think bigger about the support systems. And I know Mario is thinking about this the same way that we are, which is to say that in the old days, when we talked about care coordination, it used to be, are you getting your MRI and are you getting your pharmaceuticals? Now, when we think about care coordination, we think about social determinants of care. We spend a lot of time in our enterprise. We have 13 neighborhood care centers, physical locations where we're offering programs to the neighborhood. Anybody can walk in, help with food insecurity, help with apartments, help with SNAP, things of that sort. Now, as a result of this COVID crisis, all of our team members are remote, but dealing with many, many more issues, the kind that, Michael, you're talking about as well. So this has given us a whole new appreciation to the role that a health plan can play in the community, linked into community providers. One of the things in our enterprise we have 42 medical offices, primary and specialty care centers. And we've just recently partnered with the mayor and the city of New York to bring testing to hotspots that are chronically underserved. And that's given us a whole new perspective about what are we seeing in these communities, what more can we be doing through the physician side, through our neighborhood care support, or through the health plan. But you're quite right to set the bar high. And I think there are a number of things now that all of us in the health plan community are going to be doing, and using a variety of technology, people, and other kinds of solutions to do it in innovative ways. And it's very exciting to think about.
Maybe one thought on this and observation we have, as well as the majority of mental health care journeys, I think, still starts actually with a primary care physician, often not going directly to a psychologist or a psychiatrist. And that generally actually is another gap that oftentimes exists, because there are not that many primary care physicians who've got themselves the support system around them in the front office or in the back office of their practice to then appropriately connect people who maybe should be connected to mental health follow-up. And I think that's sort of like, again, for the listeners and the viewers of this, it's kind of almost an important thing to know that your primary care physician, him or herself, might not exactly know how to connect the dots there to mental health resources. It's puts a little more load onto the patient or the member there of actually making that connection. And I would encourage people to really make that connection. And as insurance providers, that's another thing we try to really do a fair bit of work on as well. Can we somehow help, and again, through the concierge teams we have, through the information we send to physicians and communicate with their, to make those connections a bit better out from the primary care practice into the behavioral health community. And that's another.
I think we're talking about two different kinds of integrated care, which is, and the first bar, of course, is getting primary care providers to understand behavioral health needs and be able to refer appropriately and welcome those kinds of conversations with their clients and patients, but to be open to talking about something that's not exactly what they do. So that's the first sort of lowest bar that we need to get to, I think. But the second is what I think Michael and Karen, and I have a feeling Marjorie will also join in on, that everybody needs to be realizing that there are many factors that determine how we are feeling and what our mental health and behavioral health needs generally are, that the social determinants of health are real. And so you're asking insurance providers and the nonprofit and the private sector to either on their own offer counseling in those areas or connect with city resources that can, right? You don't necessarily have to duplicate your own and create your own alternative parallel city government, but you need to know where those resources are. At minimum, ask somebody to call 311, but encourage them to do that. But somebody's being evicted, you need to know about the one-shot deal. If somebody is talking about wanting to get on MATs, medically assisted treatment, you need to know how to do that and how to access it quickly. Marjorie, how are you trying to communicate with the hardest hit communities and get the word out to them that there's help?
I think I think we all have touched on the critical need to weave ourselves into the fabric of communities, to really have a finger on the pulse of what the needs are. And needs are broad in a diverse city like ours, where we have folks that can easily navigate technology to get their needs met. And then others who have no technology, either because they can't afford it or just are off the grid in certain parts of the city. So we take real time to work with organizations in the community, whether they be faith-based organizations or community organizations that work with individuals with different cultures and different languages and different perspectives about what health is and could be. Because our language is not always every New Yorker's language about what primary care is for them, what mental health care is for them. And particularly now, I think we've all said that individuals don't come with one need. They come with multiple needs. So that I really applaud all of the enrollers who are working in this time, because they're not just doing health insurance. They are doing food insecurity and connecting people to grab and go and doing whatever they have to do to make sure that kids eat. They are connecting people to our electronic portal at HRA, where you can apply for SNAP, apply for cash, apply for one-shot deals and not leave your house. So really trying to meet people's needs where they are, but doing it through organizations that are trusted, that are comforting, and that themselves need to be bolstered with information and resources so that they can be good ambassadors and conduits.
I think that the relaxation of the rule that you have to come in person and bring your documents is not only appropriate in the COVID era, but I think what we will likely find is that many people who have fears about coming forward anyway, perhaps they're undocumented, perhaps they're worried about something else in their documents, that all sorts of people who might otherwise not have come forward will. And so some of these regulations, I think everybody's wondering, can we keep them even after this crisis moves on? Can we still have telemental health? Karen says, there's no turning back. Marjorie's smiling like, maybe we'll keep doing the electronic enrollment.
Well, I think there's going to be a fair amount of policy thinking and advocacy, frankly, based on what we're seeing and we're learning by using these new tools, new technologies, and building different relationships. I think that we are steeped in the inequality conversation for many reasons. And technology is finding ways to level playing fields that have never been leveled, frankly. So I think there's going to be new advocacy around how do we use our systems, our tools, our relationships, our platforms in ways that finally get resources to everyone that needs it.
Yes.
And this is where different sectors can come together, which is a very good thing.
Yeah.
I'd like to pull back just for a minute because I think there may be many viewers who perhaps had accessed behavioral health care or either for substance use disorder or mental health problem years ago and had a certain kind of experience with insurance and the lack of coverage that may not be aware that many things have changed over the last several years. Karen, could you just talk a little bit about the parity regulations so that people understand what the new landscape is?
Well, literally speaking, the parity regulation requires us to offer mental health coverage in the same way we offer acute care coverage. So there's no longer a line of demarcation that it's on, an equal playing field, equal footing. And that gives us an opportunity to really think more holistically about the whole person and not just a body part by body part discussion in terms with healthcare itself is often that way. So it allows us to pull back and say, what does someone need across their patient journey? From an acute care perspective, from a primary care perspective, prevention, all the way to mental health. And we understand now that we have to think far more holistically about the whole person and not just about a particular episode that a person may be experiencing, or that may be their opportunity to interact with the healthcare system. So while you're at it, the old phrase, try to lay in policies and procedures that tease out risk factors for mental health conditions. And we're only at the beginning. This is a developing area in the whole spectrum of clinical supports, but I think this is the future of mental health services. So where you have someone in for a cardiology episode, in our clinics, our practitioners have begun, they use a template to ask, are you depressed? Are you feeling safe? Are you feeling secure? We'll add to that now as a result of this pandemic. But those are the most important things that can be done for people so that you're looking holistically.
And what does that mean for an individual? Does that mean I can just go to a therapist and have a copay all the time? Does that mean I need pre-authorization? How does that work?
Yeah, you don't need pre-authorization to go, And New York State did, I think, something very important. They waived during this period, copays for telehealth and for mental health services through telehealth. We embraced that, and they did it for so-called essential employees. And we thought everyone would think of themselves quite appropriately as essential. So we just did it for all of our lines of business. And that has opened up the windows and brought more people in, because you're meeting them where they are and you're making access easy. That's principle number one. How do we make access easy? How do we make people feel comfortable with the access? And how do we make sure they have a very good experience so they come back? And that's very important.
So I want to do something fun with you. I want to give you the opportunity to ask one question that will elicit a very short answer. So each of you can pick anybody on the panel that you'd like to ask a question to. You don't have to, but if you have a question, and I think Michael's got one, you can ask it and brief answers, and we'll go all the way around. Michael, did you have a question?
Can I go? I'll go third.
Okay. Okay, who wants to go first? Or I'll keep asking. Who wants to go first?
I'm gonna think about a good one. I have one shot. I gotta think about a good one.
Yeah.
Okay, I'll go first. I'll take the bait. Michael, if you could change anything, because listening to what you had to say, and Marjorie, if I could get a twofer, I'd ask you too, based on your perspective, but I don't know if Susan will permit that, so she's the boss. But Michael, if you could change anything based on your years of experience in terms of addressing mental health issues, what would it be?
Wow. I think I would think about really innovative ways of reaching people, and how we think about treatment or kind of access to services. So like I said earlier, I think people oftentimes will think about therapy, but I think we've been really kind of fortunate to be able to really kind of do some innovative thinking around using community health workers, peer people lived experience, to kind of go into the communities, have these conversations with people around their stress, around their anxiety, around connecting them to mental health, physical health, social services. So I think it's about expanding how we think about mental health services, because there are many more people who don't have PhDs or don't have masters who really have their own experiences that they can use to help people out.
Great. So you would redefine how we think about mental health services and go beyond sort of degreed, sophisticated work to thinking about mental health support.
Yes, absolutely. Yes. I mean, there are people who just cannot have a difficult time connecting with various communities. So I think getting people who understand that community, feel that part of that community, I think that they're probably the best ambassadors for really being able to promote mental health services.
Thank you. Marjorie, you have a question?
I think I'm going to ask this broad question, and anyone can answer it, even you, Susan, because I think the struggle that we're all talking about is normalizing the conversation about mental health being as important as physical health. So what ways can we take on, and I think that Karen gave one opportunity as leaders to bring that into our teams, but how do we take that broader? What else can we do to normalize that level setting about mental health care?
One is a little bit in the weeds, but I think one thing we see is that if you open up anonymous channels for people to engage in mental health resources, that again lowers the stigma of engaging. We have certain digital health solutions where you can initially kind of chat anonymously, and that gets more engagement. And so a sort of like very simple product idea would be make that more available more easily, whether through technology or a phone or anything like that, that could draw more people at least into the conversation there early on, and then go from there.
I would say that one of the things that I found successful, we have numbers that are sort of out in the ether a lot these days, and we talk about how 1 in 5 people in America faces a mental health challenge every year. And that doesn't mean a serious mental illness, but it means a mental health challenge that prevents you from enjoying life to the fullest every year. Then we have all these numbers about people who, even though that's true, don't seek help. But I always try and ask people, if it's 1 in 5, it's either you or someone you know. That's a very tight little ratio. It's all of us. It's not a problem that's out there. It's people we know, it's people in our families, it's ourselves. And that's the beginning of the conversation, to talk about how profound these mental health challenges are in this country on a regular basis. Now with COVID, I think the experience of challenges are so much more profound, so much more extreme, that people feel in some ways, maybe, I agree with Michael, there's a sort of a sense of solidarity. We're all experiencing this, and so it's a little bit more okay to talk about it. It's a little bit more okay to be asking people on a regular basis, how are you doing? Right? How, you know, and to expect that they're gonna talk about that they're doing okay given the circumstances, but they're not great. And, or they'll say more than that, that they're really grieving, or they're so depressed they're having a hard time. But I think we have it's a terrible thing to talk about sort of these silver linings, but I think we have an opportunity that this crisis has created to emphasize how much all of us experience mental health challenges, and how much all of us would benefit from help on an ongoing basis, and to just normalize it. That's why, you know, we were joking before, but the even Mario comment is really a wonderful one, that it's all of us. I'm trying to be as open with my team as well, that it's very hard for me as well as I know it is for you. And I think that's helpful.
Yeah, you're getting to the point that leaders are afraid to be vulnerable.
Mm-hmm.
And you can say that for physical health, but then you add emotional health into it. And it's almost that you have to force yourself to give voice to what you know the people you lead are feeling.
Mm-hmm.
They are afraid to go to the grocery store still. They are afraid to go into Walgreens. They're afraid to get onto a subway. So what can you as a leader do to create policies to support them? But also, how can you give them space to both articulate that, but also to talk to somebody? For us, I spend a lot of time talking about, remember, we have an employee assistance program, we have wonderful mental health benefits, you know, you're feeling stressed, et cetera. And I go out of my way to do it because I think that's part of our obligation as leaders, just to do what we can to put that hand out for someone virtually today, but you know.
Yes.
Exactly. And actually, I mean, one very simple thing is to honestly answer the question, how are you?
Yes.
For the first time in my life, I'm getting honest answers from people to that question, actually.
Yeah.
And that's a pretty powerful thing. You know, you can now, and we should do the same thing. If people ask us, how are you? We should answer very honestly with how we are on that particular day. And that will, I think, open the doors to others doing the same thing. And that's, that can be powerful.
And it makes life really interesting.
Yes.
That too.
Anybody else have a question? If not, we have one from a viewer. Did you have one, Michael or Mario?
I have one question, just either for Karen or for Mario. What have been the barriers that you guys have identified in reaching hard-to-hit communities? Hard to reach communities, yeah.
I think one of the first barriers, without a doubt, is the situation where people who are in hard-hit communities are needing to go out to work. They're not at home, number one. They have more vulnerability than those of us who are at home primarily, versus working at home versus not going out. That's the first thing. The second thing is the amount of chronic conditions that people face, diabetes in particular, and other kinds of cardiac disease and so on, obesity. That relates to food availability and so on and so forth. So that, I think, taken together, the fact that people in communities that are hotspots in the city are very vulnerable to chronic conditions and suffer from chronic conditions. You put all of that together, and that is the reason that I think we see the rates of COVID in certain hotspots. And it gives you, I think, a window in terms of where we go forward and how we learn from this and how we do better. It gives you a window into what it means not to have a public health system in this country. And where do we have to rebuild? Where do we start? Testing, clearly, contact tracing, very, very important. But how can all of us in our different sectors work together to say, we've got to restore and rebuild this public health security blanket, because it's not secure anymore. And that's where I think a lot of this, it's a great question. I think that's where a lot of this starts.
Yeah, I would say financial constraints, and I think Karen talked about this earlier as well. It is just now the case that it is getting harder to afford premiums, harder to afford medications, harder to afford daily living expenses for many people who are affected by the financial crisis, economic crisis now, related to the virus crisis. And I would also again say we're trying to do that too. We're working with a team that connects people to city resources and state and government resources and so on. Again, there's a lot more available, as you already mentioned before, than people generally think. I remember a member of Oscar who was in the 70s, got laid off, is on $1,200 Social Security per month, struggled to pay the bills. And I think the team was able to connect her to programs worth $10,000 a year that come from the city and the state and so on. And that is available. But that connection's got to get made. And so I think the best thing there again is, call your insurance company on the one hand, but also call 311, talk to somebody from the city to see what the programs are that are available there. I'd say the second thing I would say, and this was going to be actually my question to almost Karen and I, but also the rest of the panel. I want to first say Emblem, I think, is doing a fantastic job, Karen, in this crisis, and certainly on the behavioral health side as well. We learn a lot from you as well at Oscar. One constraint I think that we still face, and do think is a citywide problem, is the relatively thin network of in-network mental health providers.
Yes, exactly.
When we look at kind of the general medicine providers, about 80% or so are in some insurance companies' network. That number is 45, 50% or so for mental health professionals. And that's still an access problem in many parts of the city for just finding an in-network provider there. On top of that, the ways to find those providers aren't all that great oftentimes. The data isn't that great. Who's focused on whom isn't that great. We've got folks who have, let's say, LGBTQ plus specific topics they want to discuss. How do you find a provider who's focused on that? That is almost non-existent data. That's why I would ask the panel, how can we get more folks in network, and how can we get the kind of the accessibility there better as well?
I want to throw in a subset to that, another question to that. Mario, you're at national. Oscar is all over, right? And
but
with telemental health, why not connect somebody in Brooklyn to a therapist in California who has the specialty that they need?
Definitely makes it easier. I think the lower barriers for telemedicine generally, and I'm like Karen, I think that's definitely here to stay, and we're doing a lot of work in that area, is going to make that easier. It's going to help with the access problem. I don't think you can do everything in telemental health, though. I think in telehealth, and I think mental health, we just don't know yet, frankly, how much you can do in telemedicine. I think what is going to happen also is that the folks with chronic conditions, there is that the problems will get bigger and bigger the longer we can't go out. Right now, there are people who should have already gotten their colonoscopy, should have gotten their diabetes check in person, foot exam, and so on. They're not getting it. That'll hit us in a few months down the road. That's an example for things you can't do remotely, but absolutely, Susan, I think you can do a lot more with telemedicine, at least ease some of the access problem there, at least in the first go around.
Well, mental health care, at least. There's a lot I think we could do that way. I think it's going to open up some of these opportunities.
Yeah,
I think Mario is absolutely right to flag this issue. I think it's a sleeper issue. So Mario, I'm really glad you gave voice to it. One of the things that we've been doing, I'll give you an acute care example, and then I'll talk about mental health. In our clinics, Advantage Care Physicians, 5 boroughs, we have formed a partnership for training of nurse practitioners with Columbia School of Nursing and with Pace School of Nursing. We're talking about doing the same thing in mental health. How can we give residency opportunities, training opportunities to keep people in New York, training in New York, training in hotspots? This is part of the public health challenge. Do we have enough practitioners? Can we get them in network and make it affordable for people? So Mario, it's a great call out. I think it's very, very important. And the in-network, the significance of that is that people don't pay out of pocket for it. It's part of their premium. The out-of-network is that you're paying an extra premium for it. And that's why this point that Mario's making is so important.
Yeah.
I will say I know there's been a lot of conversation around telehealth and how it's kind of a great kind of addition. I don't think it substitutes kind of in person. Because I mean, a therapeutic relationship is about a relationship, right? And so even if you're kind of at distance, at some point you want to be able to be in front of that person to have the conversation. And also, I think it's about really, I think it's a good kind of gateway into having kind of this relationship where you can have an in-person one.
Yeah, exactly. Right.
The end all and be all and forever, because there is value in that personal connection in front of somebody and being able to even be in that space to have the conversation, if that's what prevented you from having it in the very beginning.
But it's a door opener.
Yeah, it might be also
good point. Yeah, good
to
point.
find a good provider for the future, right? If you are able to talk to 3 or 4 providers in the future and you can sort of like really see where do I have chemistry, that might be a great way to use telemental health in the initial kind of go around. But then eventually, yeah, I would also say you need to build that relationship in person then.
We are near to ending. I'm going to say we had one question that came in from people who pre-registered for this event and sent in questions before even seeing the panel. And the question is actually for Marjorie and Michael, and I will ask you to be brief in your answers. What do you think what should be our city's priorities for action steps to foster mental health for our citizens during this crisis? So pull back from the insurance questions, pull back from the coverage, and just say, what do you think the city should be doing to promote positive mental health? Action steps.
I'll go first. I'm sure that Michael has much more to say, but I think the issue of normalizing the conversation around how are you doing mentally is important. And I think the way that we can do that, particularly for communities where there's sensitivity to answering that question, is to use all of the various voices, whether they be radio voices, because every community has a radio channel that they listen to that's either official or bootleg, that puts out messages that they can hear. So I think the more that we can say, we understand that everybody is not all right, and let's talk about it. And there are ways you can talk about it, and there are resources that you can get to talk about it. I resonated with Michael's point about community health workers, because I do think that we need to continue to invest in them and build a cadre of folks who look like, feel like, talk like, live like some of the hot communities that we're trying to reach. And I think those relationships can be the on-ramp to more vested primary care, mental health relationships in the future.
So again, it's redefine, speak to people where they are and redefine what mental health support looks like.
Absolutely.
Michael?
I'll add on to that. I mean, like I said before, I think that the important part is having the conversation to destigmatize. I think that kind of from an equity perspective is, we focus on the areas that are hardest hit, from, COVID-19 morbidity, mortality, who historically have had the highest kind of behavioral health challenges in those areas. I think it's about focusing in those areas, prioritizing those areas to make sure that we kind of give them that that they're able to achieve the highest level of health.
I think if I had another few hours with the 4 of you, we'd be making great progress in our policy work and our delivery of healthcare in New York City. I very much appreciate this lively and informative conversation, but mostly I want to thank all of you for bringing such a great level of dedication and creativity to your work. It's very clear that more can be done, but that each of you has contributed so much to where we are today. And I speak for many people in thanking you for your great work. I've learned a lot in this conversation. I hope our viewers have too. I imagine they have. We've covered lots of themes. We've talked about our mental health challenges that people in New York are facing right now. We've talked about how to access insurance coverage, and that insurance coverage this day is not your mother's insurance coverage. It's different. And the more people know what is happening now and what is possible, the more they may be likely to reach out for help and reach out for care. I do also, as we wrap up this evening or this conversation, I also want to remind our viewers that there are also other free services that are available to you. So if you have a loved one or you yourself are struggling, help is available, and you do not have to handle these problems and challenges alone. So if you look on the screen, you see that New Yorkers can visit the ThriveNYC page, which is nyc.gov/ThriveNYC. And right at the top, you'll see on the menu, mental health support while staying home. And it's a guide you can read that tells you about resources that lots of our agencies are offering, from the health department to the Department of Veterans Services to the Education Department. So there are services for all New Yorkers, but there are also services tailored to the needs of aging New Yorkers, veterans, children and students, and people harmed by violence, crime, or abuse. So please visit this guide online, and also follow us at Mental Health NYC on Twitter so that you can get the latest updates. We update this guide regularly. So thank you for joining us. Please reach out. Know that you do not have to handle mental health challenges alone. Help is available. Thank you very much.